I can't tell how many folks are.
It looks like we have 10 people, so minus the four of
Okay,
us, we have 6 people so far, but we will get, I
okay,
imagine we'll get more. So,
okay. And
um,
if, yeah, we can consider that as we move forward, but let's go ahead and get started. Hi, good afternoon. My name is Gretchen, and I'm here today with my colleague and my good friend, Dr. Sherilynn Chan. And we have the opportunity to kind of lead a discussion today about how we talk to kids and teens about death. So, before we kind of jump into that topic, we wanted to share a little bit about the work that we do and kind of how we got here. So, go ahead, Sherilynn.
Thanks, Gretchen. So both Gretchen and I are part of a very large psychosocial team that provides services to patients at Seattle Children's in the Cancer and Blood Disorders Center. So Gretchen is a mental health therapist and I'm a pediatric psychologist. We work really closely together on our psychology team, and we provide mental health therapy to patients and sometimes their caregivers and siblings, and provide this with a continuity of care model. So we might see them inpatient, outpatient, in person, via telehealth. We sometimes see them individually or sometimes in groups as well, and support patients and families along the spectrum of treatment from the time of diagnosis and through end of life or into survivorship. So we're really excited to lead our discussion today and our learners along with all of you, and really looking forward to hearing more from all the different experts in this room and also learning from each other.
So I have had the opportunity to meet some of you during our fall workshops, but I want to just maybe do just some very quick, since there's so few of us, just some very quick introductions. So if folks don't mind, could we just, I'm trying to think about how we can do this in a way that is the easiest. Maybe let's use our chats. And if everybody, if you don't mind, if you could, in the chat, go ahead and share where you are and where you work and what you do, just really briefly, so we have a sense of who else is in the room. So go ahead and spend a minute and set that in the chat. See quite a few of us Seattle Children's people. Ooh, music therapy, that's cool. Got a few physicians. Awesome. Awesome, you guys. Just, I think it's helpful just to know like who's here, who's in the room, and just so we can kind of get a sense of that as we move forward. So, but we also want to keep good time. Whoops, I'm sorry. So the good news as we move forward into today is that we've already been learning a lot of the skills that we use when we're talking to young people and when we're talking to them about death. So we have spent a ton of time during our fall workshops practicing asking for permission, giving headlines, and working to learn more about our patients and their families. So today our objective is to look at a couple of case studies. And what we want to do is we really want to practice noticing the information that we need in order to be delivering headlines and asking questions and using nurse statements when we're talking to young people. So we are really working on our assessment of the specific developmental needs of young people when we think about then tailoring the information that we've already been practicing and learning. So our goal for today is to have this be a really interactive space. We previously, like in this week's module, there is a video, a homework assignment that is another presentation that talks about kind of the history and other details about how we've talked to children about death. And I want to plug that resource because it's a really helpful and good resource. But today is actually, our goal is to have it be a little bit more discussion based. So when we're giving prognostic news to kids and to teenagers, what do we need to think about, and how do we put this into our brains?
So here is our first case study that we will review together. So our plan is to read this through together, and then we will break out into small groups for some smaller group discussion, and then come back together as a larger group to share what we all came up with. So I'll start by reading this together, and then Jess is going to put this case study in the chat. So when you go into your breakout rooms, you'll still have this for reference. So Angela is a 9-year-old with end-stage heart failure, secondary to chronic rejection of a previous heart transplant from when she was a baby. She is not a candidate for another transplant. Her symptoms have been worsening. She is now hospitalized for titration of her milveronate therapy. After numerous discussions, her family has elected to promote Angela's comfort and quality of life above all else. They will not have her transferred back to the ICU or pursue other invasive interventions. They are comfortable with hospitalizations to optimize her medications in hopes that she can continue to have more good time. Her cardiology team believes that given her recent trajectory, she likely has weeks to months to live. In response to the parents' wishes, all of these discussions have been without Angela's participation. You have developed a relationship with the family, and this week they asked you to join them in talking to Angela about what's next. Gretchen, can you go back one slide?
Sorry, my bad.
There we go. Other direction.
Okay, my apologies. I don't know what happened there. Nope. There, sorry, Sherilynn.
One more. Perfect, thank you. Okay, so just wrapping up this case study, they shared that they are feeling overwhelmed at the idea of having to disclose this to Angela and wonder if it would be better coming from a professional. Okay, so
right.
On the next slide, we have a first discussion question. So we want you to take a little bit of time to think about what additional information you want to know from the family as you consider how you will approach communication with Angela, and come up with some really specific questions that you will ask Angela's family to get this information. And thinking about some of the frameworks and skills that you've already been learning, think about how you might adapt the 7 questions, remap, and the house model to this purpose.
Head west on 13th Street North toward Hadley Avenue North, then turn right onto Hadley Avenue North.
Okay, so how many people do we have on the call right now? Looks like we have 8 participants. So I guess we'll break off into 2 groups of 4. We'll have those discussions in the chat as well. We're gonna break for about 5 minutes. I know that's gonna go by pretty quickly, but see what you can come up during that time. And then once we get back, maybe we'll start with, let me see, Erica, would it be okay if we just start with your group? Either yourself or another kind of representative from your group can kick us off. Wonderful, thanks so much.
Okay, if you're ready, here come your breakout rooms. You'll go there automatically this time, and we'll pull you back in about 5 minutes.
All right.
Well, welcome back, everybody. Hopefully you had some interesting and rich discussion together. So I think we were going to start with Erica's group. If someone from your group would be willing to kick us off and start sharing what some of the questions you came up with, and how you might adapt some of those other frameworks for this particular patient.
Okay, so we talked about acknowledging the difficulty of the conversation and then exploring what Angela already knows about the situation. Followed by talking about what brings Angela and her family meaning and purpose through the experience of the illness. What hopes do they have? What concerns do they have going into the conversation? Explore reasons why the family feels like it might come better from a professional, and if there is a specific staff member they've identified that they think the information will come best from.
Wonderful. Thanks so much for sharing those really great specific questions that would really aid in getting to know this family better and could guide some of those future conversations. What about the other group? I'm guessing you might have come up with some similar questions. So curious if there are similar ones you came up with or any new additional ones.
It's always hard to know who's going to answer first, but I'll start and then others in my group. We all have pretty similar thoughts. We also thought about what religion they were and what their faith system was, but certainly kind of respecting the child and sort of aligning with her as far as what did she like to do, what are kind of her goals. Maybe it's to get home and sleep on the couch with the cat or that, but very similar to the first group.
I think one of the things that we also had was if they can talk about what previous experiences the child might have had with death or dying of pets, family members, friends from the hospital, things like that.
Did anybody think about like what kind of headline they might deliver? Like any specifics about a headline for Angela?
Was that part of the assignment?
No, I'm just freestyling.
We'll get to that. We will get to that.
We'll get to that. Okay, we'll get to that.
We're just so eager to get to some of the good stuff. Yeah, but really, really nice job for both groups coming up with those questions and specifically tailoring those to Angela's developmental age. Some of these questions, might be different from what you would come up with if you're working with an adult patient with a different, family context. But I think you all were really thoughtful in giving this some of those developmental considerations. Okay, so let's jump to our next discussion question for this case study that Gretchen gave us a nice little peek into. So the next part we'd love you guys to think about is imagining that imagine that Angela's mother wants to have a conversation with Angela about her prognosis together. So what are some of the other developmental considerations when talking to Angela directly? And then how might you adapt your headline to her developmental stage? So we will give you about 5 minutes-ish again to go over this. We know those headlines can take a little bit of time to be thoughtful in crafting, but we will, take about 5 minutes and then regroup together.
Are we assuming she's sort of a normally 9-year-old or not?
I think that is maybe part one of that question, thinking about, what might you take into consideration, and then maybe as a group you could decide, based on whatever scenario you might come up with, what would be an appropriate headline.
Okay.
Great question.
Okay,
now
Sherilynn.
it's the
Sorry, I missed that, Gretchen. Are you both ready to open rooms one more time? Okay, here you go.
All right, welcome back, everyone. So we were discussing developmental considerations when talking to Angela directly, and then coming up with a headline that would be tailored to her developmental age. So why don't we start in the same order with that first group, if someone wants to share with the larger group what you all came up with.
Okay, so we got sort of halfway through our headline. We talked about using, in terms of developmental consideration, we talked about using very direct language, not using metaphors, that sort of thing. So for our headline, we came up with, your heart is very sick and we don't have a way to make it better. And then as the discussion group closed, we were talking about how to say that we are worried that that this was going to take her life, and that we wanted to support her in the things that she wanted to do and help keep her comfortable. But we didn't quite get the second part of the headline done.
We rushed you, in fairness.
Great, thanks for sharing that. What about the second group?
I think from us, I feel that the first part, as in, a variation there of what sort of the first group also did with, your heart is very sick and the medicines, unfortunately, they don't work anymore to make it better. But the second part is the hard part, right? When you are saying what's going to happen, because besides being very direct to a hopefully developmentally appropriate 9-year-old that has some experience maybe with death in the family or whatever, it's hard. And so we were, struggling with that, I think, and coming up with things that something along the lines that your heart and your body will get weaker, and eventually that means that your heart will stop working and you will die, which sounds so rough. I mean, I've never had, as I'm a neonatologist, I've never had to tell a child that they're going to die. And so this is just like really hard work. Yeah.
But Robin, I think, had a good idea in our group to have some hope in there. So yeah, your heart's going to stop and die. And Robin, you can probably do it better than I did. But we hope that until that happens, that you can, whatever she wants to do. So also give her that news, and maybe she knows that she's going to die. I mean, she probably feels it if her heart's failing.
Mm-hmm. I really like that you're thinking about the information and the meaning of the headline. You said that really clearly, like, okay, now this is the hard part where we have to say what that means. And thinking about all of those questions that we talked about before, like putting the context of who this kid is and what their preferences are, all matter in terms of like how we state that meaning. You know what I mean?
And then adding to the meaning that compassion or that hope. It sounds like that's a critical piece of it and a really difficult part of it too. Any other final thoughts before we move on to our second case study?
How would you guys do it?
Oh, don't worry, we're gonna get there.
Oh, okay.
We have some slides. Yeah, no, we're thinking about like, I think part of our goal is to think about all of the ways that we're assessing a specific child and trying to think about the information that we need in order to deliver the headline. So unfortunately, there isn't like one easy answer, right? In terms of how we state this or how we give this information. All of that context matters so hugely, but we're gonna think more about what the specific, we'll give some examples, I promise. But I'm going to share my screen again and we're going to go into our next case study. And I know we're putting in a whole lot of content in this hour, so thank you for bearing with us. Is that working? Okay. So I am going to go ahead and read this out loud. So for our next case study, Freddie is a 17-year-old non-binary teen with widespread metastatic osteosarcoma. They're currently inpatient for pain management after learning that their disease has returned. The team is about to present a plan to Freddie and to their mom about the options moving forward. Freddie has the option to 1, do an oral chemotherapy medication, which would require family to come to clinic about 1 time a month and hopefully slow the spread of the cancer. 2, have a palliative amputation of the right leg, which would hopefully prolong their life and also improve pain from the cancer. And or 3, go home on hospice with no further cancer-directed therapies. The team does not believe that Freddie's disease is curable. Freddie lives about 3 hours from the hospital and has 2 cats and 2 dogs that they are obsessed with. They hate being in the hospital. They had to relocate during their initial 10-month treatment when they were 15, which was challenging for Freddie and their family. Freddie has a very active social life and a boyfriend who they love. This is their senior year of high school, and they're actively involved in their school and church communities. According to the oncologist, while she did share the news of the occurrence with Freddie, they were tearful. The oncologist did not specifically tell Freddie that their cancer is not curable. When Freddie was in their initial treatment, they preferred information to be filtered through their mom. The team is unclear if this has changed. So we're going to move into, sorry, I'm having some there. We're going to move into some similar discussion questions and go back into small group for a few more minutes to discuss, like, what information do we need to know from Freddie's mother as we consider how we'll approach the communication with Freddie. So I want to hear some specific questions that you might ask Freddie's mom in figuring out what we're going to do to move forward with Freddie. And then consider the other questions that we've already talked about, the framework that we've already learned in the fall workshops. Does that make sense? All right. So Jess, do you mind sending folks back in?
Sure, here you go.
Hey, welcome back. So I'm curious, do we want to stick with the same pattern if there's anyone that wants to go? We don't have to go with the first group going. But I'm curious if folks have kind of thoughts about what they would ask to Freddie's mom.
I'm gonna apologize ahead of time. My dog is barking, but I'll be happy to report for our group. We talked about how we would want to explore how Freddie would like to get information now, and that this might be a question for both Freddie and for the parents, and how they, what their communication preferences were, because it sounds like, this may be the same or different from previous. And then assess their understanding of the situation, explore their hopes and concerns about each option, and then explore the importance of maybe upcoming school activities, given that it's our senior year. And then that we identify that sounds like the information about the cancer not being curable hasn't been delivered yet. So then we would need to deliver a headline once we got that information.
Yeah. No, that's great. That's great. I like that you thought about talking to Freddie directly too, just about those preferences. I think sometimes we shy away from kicking parents out of the room to talk to an adolescent patient. And I think that that's a really important part too, about like what those preferences are. What about our other group? Any other thoughts or?
I'm not in the other group, but Gretchen, I agree with your point, but I'm wondering are you willing to share the language you use in a situation like this to kick the parents out of the room?
Yeah, absolutely. I come in and I say, well, so I work a lot with AYA patients. That's kind of my favorite part. And so coming into a room with a 17-year-old, I will walk in and I'll greet everyone and I'll say to the parents, hey, heads up, I'm going to kick you out in about 10 minutes. So I want to have the opportunity to talk to both of you, but then I'm going to ask you to go and then I help them figure out where to go. But I literally will tell them I'm kicking them out. And generally speaking, it's not met with a lot of hesitation. I have had parents that say, no, what are you going to talk about? What is that going to look like? And then we can have more discussion around that, or maybe we need to like have more relationship building time. But I will just literally say, I'm going to kick you out, and usually with some warning.
Just to build on that quickly, I think it is helpful to be the person who sets that expectation, because sometimes if we give the adolescent the choice, they might say, oh, no, it's fine, you know, parent can stay, or they'll feel guilty about that. But if we're the ones who make that decision for them, they might actually appreciate it, or, you know, will be given that opportunity to meet privately.
What age do you start doing that?
For us, we start doing that around 13. And our roles are different because we're mental health providers. So 13-year-old patient consents to their own mental health. So we can like establish that from the beginning of care. But I'll say in my working in our HEMONC clinic, a lot of our providers that work with a lot of adolescents and young adults do set that precedent from the beginning. And they say in outpatient clinic, they say, hey, just so you know, I'm going to kick your parents out when we do the exam. And they start setting that up, and that can create like just some safety that everybody expects it, and that there's going to be some specific check-in for an adolescent patient, which I think is really critical also for them to build relationship without parents, because so many parents take up so much space during their child's treatment. Understandably, they're still the ones consenting. So there's kind of this confusing mark. Okay. I want to move on to the second part of the discussion. We're going to do it similarly to what we did before. So let's look at these next discussion questions. So for Freddie, am I doing that right? Yeah. So thinking about having this conversation with Freddie, I want you to think about how in the communication toolbox that we're already using, how would you try to engage Freddie in this specific conversation? So, so similarly to just thinking about like what specific words we would use to throw parents out of the room, like what specific words could we use with Freddie in kind of starting this conversation? And yeah, I think that's it. So we're going to spend probably just a few minutes in the breakout rooms. This is going to be the last breakout room time. So thank you.
Okay, y'all, here you go.
Thanks, Jess. Welcome back. All right, for this last one, can we just hear maybe one of the thoughts about how to begin a conversation with Freddie about this?
So we had an interesting discussion in our group about building rapport with adolescents and how quickly to get to sort of our goals for the conversation versus allowing time to build our relationship with Freddie, and that we were kind of unaware how much rapport we had already done. And so we talked about how adolescents make decisions, and that and the things that they need from a developmental perspective in the conversation, and that sort of led to this discussion.
Yeah. I think that that's such a critical piece. And I think that there's sometimes opportunity also to think about who we pull into the conversation. So if I'm like, I mean, I'm not a physician, but if I'm the one that's coming in to like have this, to deliver this news, I might want to be like, hey, Freddie, who are your people? Who else can we have? Like, who do you trust at this place that you would want to have present in this conversation? And there's such a benefit because there might be a nurse coordinator, there might be a social worker, there might be somebody from their care team that it's like, no, that's who I want to talk to. and figuring out how to pull that person in or partner with them in order to, like, sometimes we can borrow somebody else's trust. If I have a lot of credit in the bank, then maybe you pull me in so that I'm sitting there with you when you're delivering the news, and that can make a difference sometimes. I think that relational piece with AYA patients is so critical. Yeah. What about the next part of the question? So adapting skills we've already used or talked about. Any thoughts about how we would use skills in our conversation with Freddie?
Well,
go ahead.
We were talking about exploring what they know, right? And what they've heard from the most recent, what they took away from the most recent conversation they had with their doctors.
Yeah.
And seeing what their understanding is. And then if we feel there's like a knowledge gap, maybe asking for permission and offering to share.
Yeah.
The piece of that cancer can't be cured, or that the team doesn't think that cancer can be cured.
Yeah.
And then, you know, besides that, going further, well, maybe that's enough for that one conversation, right?
Mm-hmm.
And then at some point exploring hopes and worries, and then see what fits best with, when we make a recommendation, what could fit best with what they are sort of thinking about.
Yeah. Yeah, kind of where they're at. Awesome.
And Robin had mentioned, and I think that goes back to the whole trust building about things like nurse statements, like, you know, expressing respect and understanding and for the path that they've already taken.
Mm-hmm. Absolutely. I think with adolescents too, and young adults, that respect, like using respect statements specifically is effective, because they want to be, you know, a 17-year-old is more grown than I am today in my 40s. You know, they like want that kind of feeling of autonomy and feeling like they're making their choices. So respect statements can be especially effective with this age range. Okay, we're going to breeze through listen, you guys, I'm sorry. I could talk about this all day. I know that this is too short and that the content is there and you guys have to get back to work, but let's review, just kind of thinking about kind of the main points about how we're shifting the content as we're working with adolescents and with kids. So the first piece is tailoring information. So here's our headline for Angela. Angela, would now be an okay time for us to talk about what's going on with your heart? So thinking about, I'm going to go through these even faster, thinking about like, how do we tailor our information, asking for permission to proceed, to also give some heads up about what we're about to talk about. Information preferences is another piece that's really critical. So Freddie, how do you like to hear information? Some people want their parents to hear first. Some people want to know everything up front. Making sure that we have those conversations, and with AYA patients that are developmentally changing pretty rapidly, having those conversations frequently, because sometimes we have patients when they're 14 and then again when they're 18 and then again when they're 22, and those preferences can shift, like with Freddie. So forecasting, so giving an idea. This can be really hard to talk about. I have some really serious information to discuss. The news about your cancer is not what we hoped for. So giving some warning so that our patients have a sense of what the conversation's about to be. A lot of times patients, young people will say, I didn't expect it. I wasn't seeing that coming. And that can feel like a really quick way to not have trust. This piece is probably, I think, the most important piece is thinking about how to deliver developmentally appropriate headlines. Angela, your body is very sick and our focus is going to be on making you feel as good as possible. So we might not even say you're going to die. That might be part of what we talk about with Angela's parents, but so that meaning might be different. The meaning might not be all the way like you're at the end of your life, you're about to die. It might be, we're going to focus on making you feel as good as possible. We're worried your cancer can't be cured. Thinking about nurse statements, you've done all the treatments we've asked you to do exactly right. This information is hard to hear. We'll be your team no matter what. So thinking about all of those things can be really beneficial. It's laughable that we thought we would have time to go through and think about take homes, because obviously we're out of time. If folks don't mind, we have this brief evaluation about how we can use our time and how this presentation was. So if you don't mind scanning the QR code to do that or clicking the link, we would very much appreciate it. And I'm sorry that we kind of rushed the end of our content, because I would love to have more discussion about the work that we're talking about here.